Good evening. I'm Alex Trianis, Dean of the Johns Hopkins Carey Business School, and it's my pleasure to welcome you to the Carey Business School's Distinguished Speaker Series. Through our Distinguished Speaker Series, we invite the most accomplished business professionals to discuss today's most compelling business challenges. Tonight, we have a great set of panelists who will explore the rapidly evolving landscape of medical technology and the future of health. And I have the pleasure of briefly introducing each of our panelists. Joining us this evening is Erin Bartley, a healthcare executive focused on enabling health systems to achieve and accelerate their clinical transformation goals. In her role as Chief Operating Officer for Medically Home, she's working to scale capabilities to shift acute care into the home with a Medically Home model and platform. Her team has built a compelling new care delivery model, operational capability, and technology platform that safely substitutes the home for the care that is delivered in hospitals using a scalable operating platform, technology, and a high-touch care team. Before Medically Home, Erin spent more than 18 years in healthcare consulting. She also holds a Bachelor of Science in Business Administration from the University of North Carolina, Chapel Hill, and a Master's in Health Services Administration from the University of Michigan. Sathya Elumai is the founder, president, and CEO of Adherence Health, a digital medicine company based in Baltimore. Adherence Health has developed MouthLab, a non-invasive handheld rapid health assessment device designed to be used at home. In addition to his work at Adherence Health, Sathya is an advisory board member at Rutgers University, a scientific merit reviewer at the National Science Foundation, an executive member of Forbes Business Council, and an ambassador and merit reviewer at the Patient Center Outcome Research Institute. Sathya is a graduate of Carey Business School. He earned his MBA here and his MPH from the Johns Hopkins Bloomberg School of Public Health. He's also a certified healthcare quality and safety professional with over 10 years of diverse leadership experience at Johns Hopkins Medicine. Dr. Bruce Leff is a professor of medicine at the Johns Hopkins School of Medicine and director of the Center for Transformative Geriatric Research. Bruce's research focuses on novel models of care delivery for older adults with an emphasis on home and community-based models of care, including hospital at home, which he developed at Johns Hopkins in the 1990s. He co-leads the Hospital at Home Users Group, which provides technical assistance to foster the scaling of hospital at home services in the US. Dr. Leff has served on multiple expert panels, including the National Quality Forum, the National Committee for Quality Assurance, and the Center for Medicare and Medicaid Services technical expert panels. He currently serves as the chair of the Geriatric Medicine Board of the American Board of Internal Medicine and chair of the ABIM Council. He previously served as president for the American Academy of Home Care Physicians and is a former member of the Board of Regents of the American College of Physicians. He's also on the editorial board of the journal Annals of Internal Medicine. Finally, the moderator for this evening's panel is our colleague, Professor Dan Polsky. Dan is a Bloomberg Distinguished Professor of Health Economics and Policy for both the Carey Business School and the Bloomberg School of Public Health at Johns Hopkins. He's also director of the Hopkins Business of Health Initiative and co-director of the Hopkins Economics of Alzheimer's Disease and Services Center. Dan's research explores access to affordable quality healthcare through innovations to health insurance design, coverage, and payment, focusing on aging and low-income populations. He is a member of the National Academy of Medicine. He also serves on the Congressional Budget Office's panel of health advisors and was a senior economist on health issues at the President's Council of Economic Advisors. As I said, a great panel, and Dan, I'll turn it over to you now.
Thanks, Alex. Thanks for inviting me to be a part of this great Distinguished Speaker Series. So as a moderator, here's kind of the rules of the road. I see we got about 100 participants now. We'd like to engage you through the Q&A, so feel free to put in some questions and we'll leave some time in the third part for interacting with the Q&A specifically, but we'll divide it in three parts. The first part, we'll get to know our panelists with a couple of kickoff questions. Then we'll have some questions where we can engage between the panelists before we open it up to take some of the Q&A. So we encourage you to be a part of this as well. So to kick it off, I'm going to put the same question to each of you. And Aaron, we're going to start with you. I just would like to know, why health at home, what it means to you. Give us your perspective of, how you got involved in this field and how you connect to it.
And good to be with all of you. So for me, I've always been driven in work by the chance to make an impact. It's why when I went into consulting, I went into healthcare consulting specifically and got the chance to work with provider organizations across the country on improvements that would help impact patient experience, efficiency, driving better care. And when I discovered Medically Home and Hospital at Home, really building off of all the great work that Dr. Leff did, I was leading here on Consulting's Care Transformation Solutions, which were all about more value-based care, bringing more care into the home, which is where I first discovered Bruce's work. And when Medically Home came looking for an implementation partner to help scale, I will never forget the life-changing first conversation that I had, where this really brought together all the things that I always aspired to be able to do with health system partners in consulting, and to be able to do it and help build the company and the model firsthand. I'm sure everybody has an experience with family members having a less than ideal experience with the healthcare system. I've certainly had that. I am blessed to have a couple of grandparents who are in their 90s who I have seen in and out of the hospital for various ailments. The delirium that they experience when they're in the brick and mortar hospital that they don't experience, when they are at home. And this model of care, being able to bring hospital level care into patients' home, initially focused on frail elders, but many other patients that Medically Home's been able to help enable our partners to treat. It's what the care experience should be. And so being able to do that and see the impact that we with our partners are able to make in transforming patient and family lives is really what drove me to want to be involved in this, and really what drives Medically Home as an entire company.
Thanks, Aaron. Bruce, will turn to you. Are you interested in home health, and what brought you to this field?
Sure, thanks, Dan. Great to be here as well. So I'm a geriatrician, and the thing that got me excited about home-based care started when I was a resident, as a second-year resident, general internal medicine resident. We picked up, all the general internal medicine residents picked up an additional clinical experience, and mine was home-based primary care. So our hospital had a program to serve homebound older adults who could not make it into the ambulatory office-based practice because they were too frail to be able to get out of their homes. So we would go see them at home and provide longitudinal care in the home. And for me, that was a absolutely transformative experience. I learned actually how to take a history. I learned how to really do a physical because all the technology that was more available in the hospital was less easily available in the home. I think I learned how to counsel patients and devise good management plans. And I think I also learned a little bit of humility as a guest in someone's home, as opposed to when patients are in the hospital. That's kind of my fiefdom. And even though I try and be a relatively nice person, the setting doesn't always allow me, or maybe I'm just not a good enough person to be good all the time when I'm in the hospital. But in that experience, we had a lot of patients who would get acutely ill and need hospital care. And some of them would refuse because they had had such lousy experiences in the hospital, like Aaron's grandparents. And some of them, for me, I still find one of the hardest clinical decisions I have to make is when I'm sitting with an older adult in the outpatient clinic who is acutely ill, who probably should be receiving hospital level care. And I wonder, if I put them into the hospital, I know I'll be able to take care of the pneumonia or the heart failure or the pulmonary disease, but will they end up worse for wear and end up in a nursing home simply by being in that very challenging environment for older adults where they can become delirious, develop acute confusion, which can lead to long-term cognitive impairment? Will they lose the ability to function and, having formerly lived in their own place, now need to go to a nursing home only because they were put to bed for several days and lost muscle strength? So it got us to really think about developing hospital at home, which we've done over the past 20 plus years. And, you know, the nice thing that I'm seeing now is not only hospital at home, but home-based primary care becoming more prevalent and more widely adopted, seeing home-based palliative care, seeing models that focus on improving functional status, like the capable model developed by Sarah Zanton here at Hopkins. And what I see happening over the next, I don't know exactly how much time, because I think the lags are the hardest thing to predict in healthcare, but the development of a true home-based care ecosystem, a really distributed, decentralized form of healthcare where in the future, the hospital becomes a big ER, OR, and ICU, and everything else is in the home, supported by supply chain and logistics and the like. And I think it'll end up being a more equitable healthcare system and one that'll be better for our patients and for the economy. So I'll shut up now.
Thanks, Bruce. Satya, let's turn to you. Tell us what health at home means to you and how that motivates you for what you do.
Yeah, thanks for actually inviting me. I had the fortune of working at Hopkins for 15 years. I was running around different hospitals, I think working on quality and safety. So we put together a lot of programs for heart failure and COPD. But I was not a patient, and I thought we were putting together some of the greatest programs. But once the patient leaves home, we have no information about their health. We miss almost around 90% of the health information is not available for the physicians. But I think around 7-8 years ago, when my mom was first diagnosed with her chronic condition, I felt like there is a need, but it was more challenging when within 1 or 2 years, she started developing more chronic conditions, kind of downstream effect of that. And like polychronic condition is a new normal, or at least right now. So it is very difficult. She was given multiple devices to monitor her health, and there was no communication between her pulmonologist to a cardiologist. And it was really challenging. And it kind of led her to a point where she got CKD, where she didn't even know about it until the end stages, where now she's on a fluid restricted diet, which is when it really hit me hard. And we really wanted to find something that is simple to use, something that can easily integrate into the life flow of the users, more like a toothbrush. That's what my mom was using every day. She pushes a button and then brushes and then takes care of everything else. So what we really wanted to do is, like, our goal was to map health, like overall health of an individual. So we wanted to see where we can collect these health information, which is where we found mouth is a great source to collect key health information, which is what led us to start ADAR Health. For us, we built a medical device that measures more than 10 vital health parameters in just 30 seconds. It's very simple to use. So essentially, what we did is put all the things that my mom is using at home, or every time when she gets hospitalized, the physicians collect a lot of health information. So we thought, what if we could collect every day, just within less than a minute, and so that we can actually predict an acute exacerbation. We can predict a hospitalization at a very early stage, and more so do it in a more humane manner without inundating them with phone calls or other things, which is what we did. And for us now, I'm really fortunate that at least I, as a caregiver, can sleep peacefully, thinking that every day I get the data from my mom's health, and I feel comfortable. And at least this year alone, we were able to take her to the hospital twice. So we don't want it to inundate hospital care, because there's a huge shortage of physicians as well. So which is where we wanted to bring care to home. And there are pioneers like Medically Home, who have been doing this for years. And then we wanted to play a small role in this bigger vision of bringing care to home.
Thanks, Satya. And thank you all for these inspiring stories. I think what you're all talking about is engaging with the health system to make it better, more patient-centric. And the stories you're telling about the work you do, for a lot of the folks that are listening, it's like, that's not the healthcare system I know. I think it's the healthcare system that you're all envisioning for the future and working in some corners to make it happen. And it's incredibly exciting. And I guess what I want to explore with all three of you, and Aaron, I'm going to start with you, is like, why now? Like, it seems like it's something we've wanted for ages, right? You know, health at home, like two things, like they're just goods that you can't get enough of. You can't get enough health, you can't get enough home. Well, I used to think I couldn't get enough home till I spent like 18 months at home straight. But you know, these are things that consumers want, and it seems at the time there's a lot of things happening that might lead this type of transformation to accelerate. And maybe you could speak to what sticks out for you, Aaron.
Yeah, well, look, Medically Home's co-founders really came up with this concept, again, building off of Bruce's work, but how do you scale that concept of really the physician house call model that used to be what medicine was, now with the incredible logistics where everything is centralized around a hospital building? How do you actually scale that? Conceptually, that vision was created for Medically Home back in 2010, and it sat there on a shelf for years because the market and the reimbursement mechanisms really were not quite there. And Medically Home as a company really came to what it is today in 2017, where finally, I think really through the consumerism movements, as you said, Dan, there was more focus on how can we drive care that is centered around the patient. But what has kept it, kind of from growing as much as it could has been reimbursement mechanisms. And for us, if there was any silver lining that COVID has brought, the attention to the high quality of care that you can actually deliver in the home, and the support from CMS and Medicare to actually pay for that has been a game changer. Everybody's gotten comfortable through COVID with what telemedicine, looks and feels like. And for the acknowledgement, really from the federal government to view this as equitable to inpatient care and pay for it as such, has been huge. So there were transformative organizations really beginning to get into this before the last 2 years, but I think we've got the, everything sort of surrounding coming together and making this a permanent shift, a shift where this will become the default position for the right patients, for the right conditions, as opposed to something that feels different. And in our experience, once patients have gotten exposure to this model, they ask for it again and again. So that consumerism movement and the demand from patients, we certainly believe is really going to grow. And now that there is a path for reimbursement and regulatory, although not permanent yet, certainly other payers are interested in the model and the savings that can come from the model as well. But that has been the key to unlocking another level of growth for home care overall, but certainly for hospital at home.
And just to build on that, agree with everything that Aaron talked about, but one thing I'm not quite sure, and just want to make sure the audience is clear on what we mean by hospital care in the home. So this is not just telemedicine like a clinic visit or an app on your phone. This is really full-fledged hospital level care being delivered in the home. So someone going either from, someone who shows up in the emergency room or the clinic has an acute, often medical illness that requires hospital level care. So they meet the thresholds to be admitted to the hospital, very important. You don't want to provide hospital at home care to someone who could leave the ED or the doctor's office with a prescription for a pill or something like that. They qualify medically. They're not so sick that they need an ICU. or whose illness acuity it goes beyond the capabilities of hospital at home. And they also have to have a home that meets requirements as well. You need a roof over your head and running water and, you know, appropriate temperature controls and, you know, some level of hygiene so it's safe to provide care. And then that person goes home and gets what they would have gotten in the hospital at home. So they get nursing visits at home and physician visits at home. Back when we started in the 90s at Hopkins, it was physicians in person. You're now seeing models that will do physician via televideo, facilitated often by another professional in the home standing next to the patient. Patients getting IV medicines and IV fluids and respiratory treatments and oxygen and skilled therapies and echocardiograms and ultrasounds. You can do a lot in the home. There are now portable CAT scans. There will be portable MRIs. These things are all coming. So just to get a sense of, you know, that's the level of care being provided in the home. So ED to home, where someone starts off their admission in the acute hospital, still needs hospital level care, but can then get the rest of their hospital level care in the home instead of the bricks and mortar hospital. So that is what we're talking about, just to be clear. And I agree, going back to the points that Erin was making about the notion of payment being a major facilitator, especially the hospital at home, the acute hospital care at home waiver from CMS, which pays the same rate for a hospital at home admission as what would be paid for a typical bricks and mortar hospital admission. That payment waiver available to hospitals who apply for it from the Center for Medicare and Medicaid Services. And that is due to last only as long as the public health emergency lasts. And a lot of folks now are working to try and get that extended or to become a permanent Medicare benefit. I would add that I also, in addition to payment, in addition to the notion of developing the supply chain and logistics to support the implementation of the model, which is not trivial. You know, this needs to be done without Scotch tape and Post-it notes. It really needs to be a truly embedded system. But I think another major barrier, which I think COVID has done a lot to start to push on, is the notion of culture change and leadership in healthcare delivery. You know, a lot of what gets done in healthcare, it just gets done because it's hardwired into the system. And that takes leadership and culture change to make happen. And I think, you know, there are a lot of interest developing in hospital at home, I would say, in the year before COVID, much more in the 20 years before that, but COVID has just taken it to a whole nother level and really helped to accelerate that notion of leadership and culture change that we need.
Just to add on that, I think, you know, regulatory reimbursement, these are two key things, and COVID, but also technology has provided a lot of like tailwinds to this effort. Like 10 years ago, actually, this was the first version that we built. and when we actually took it to physicians, they're like, what is that? And people didn't really even get the fact that why should somebody measure multiple parameters? The fact that one thing is good enough. I mean, somebody with a lung condition, I think a pulse ox or a spirometer devices would be good enough. But actually today, with the advancement in AI and machine learning technologies, and also technologies like what we are building, there's a lot of breath-based technologies, or there's biomarker collection technologies. What it does is actually it's simplified that, I think, and then with the support of the FDA, now physicians believe that, okay, I can probably get the kind of care that patients could get in a hospital setting, provided we have some form of technology to support, which is where hundreds of companies are really focused on platforms to even do hospital level care. So definitely the technology has played a significant role in making this. And thanks to COVID, in a way, it helps shape our healthcare a little bit.
Thanks. So, and it's great to see some questions coming up in the Q&A. Please keep them coming. I'm going to come back to them in a minute, but just to kind of layer on to this, exciting, we got the ball rolling here. It seems like the winds that are back to make all this happen really quickly, but there are winds that go in multiple directions in our healthcare system. And so before everyone thinks they're going to get health at home tomorrow, maybe you can speak to, what it takes to, why it doesn't happen overnight, why the healthcare system moves slowly, and what are some of the barriers that are still, still in place that need to kind of be overcome to get this to grow. And I see Bruce is the first one to take his mic off, so we'll
Yeah,
start
so
with-
I think that's a great question, Dan. I think part of that does go back to that notion of leadership and culture change, and the difficulty and the challenges of really changing hardwired behavior. And for those of you on the call, I would ask you after the webinar today to go onto YouTube and put into the search engine backward bicycle, which is a great metaphor for, I think, the challenge of change. So a guy has people build him a bicycle that's backwards. When you turn the steering handle to the left, the wheel actually goes to the right. And the guy thought it would take him just like a few hours to learn how to ride this bicycle, and it took him about 8 months. And he uses it as a metaphor for the challenge in changing hardwired behaviors. Even if you understand you need to change, it's different from knowing how to change and from changing the glide path. And I think we see that in healthcare. So, when COVID hit, my own outpatient clinic went from 100% in-person visits, because that's how healthcare is organized, around the in-person visit. We went to 100% virtual. And then as things eased up, we're like 99% in person again, because the system is built to do that. And changing that hardwiring is a challenge. Payment really does help to facilitate that. And then having, pioneering companies and technology to help change the wiring. That's one of the real main reasons, at least in my head, as to why it takes a while. And you have to bring the whole system along with you. So Medicare changes payment, the commercial payers start to pay attention, the Medicare Advantage plans start to pay attention, but it's a slow chain reaction, and it does take time. And you are seeing big players start to move into this area. Humana, if you read what they're doing, they are tilting towards the home. A lot of startups tilting towards the home. All of these things will push it along.
And I mean, from my perspective, I think it's the accountability. Who's accountable? It's a bigger question. So, which is why if you ask a physician, probably he would let you take one or two of his patient or her patients who are completely non-adherent, somebody who's completely not in sync with all the care plans, but others they really wanted to take care, and then we don't know who's going to be accountable for what happens to those patients. So, which is why there is a challenge in adoption or moving towards. But I mean, there are a lot of new companies coming up that are trying to take complete ownership of the patients, and then they do it in partnership with the payers, which kind of helps in a way. Still, physicians have to be part, I think in some cases, center of all these different conversations. I think whenever, at least when CMS or others, the regulatory agencies make sure that who's accountable for, and then there's appropriate measures, then it'll be far more easier for adoption and I think more room for other opportunities within healthcare.
And I would just add, I think we see very early, both in the providers that we work with and payers that we help our provider partners, move on this journey with. Everybody is supportive of it conceptually, right? They see the outcomes from study after study that generate better outcomes for patients. But it's hard to then reflect on the fact that that means that what I've built with the physical space may actually now, where it was originally built for quality and efficiency, it may not actually be the best place to drive quality. And that's a hard admission to make. And even when conceptually, that this is the right thing for the patient, however I am incented at the bottom line is a core element, to that change curve. And we see that organizationally, and we see it at the individual level as well. And the other anecdote I would get, I think we spend a lot of our time initially with organizations, once they understand the clinical model, talking about the regulatory framework. When you're doing something transformational, it fundamentally doesn't have a regulatory framework defined. And the risk and compliance folks within an organization, it's their job to think about that on behalf of the organization. And it's hard to move into a gray zone and to commit to that. So it really takes a leap of faith among these organizations to move into this when there are a lot of unknowns. But that's where I think resting back on the clinical data is so critical. And then ultimately, we've got data coming forth more and more about the savings. So it's not only better quality, better experience, but it actually drives savings in the model as well. And then you get to the point where you contend with, I've invested in all this real estate. What do I do with it? Right? If I'm going to shift 20% of the care or more into the home, not every provider out there, has its hospital full. And so that's a big endeavor to commit to redefining that space for wellness, for even higher acuity. And so it's just a very large commitment, but one that I don't think folks can move back on now, right? We've got that momentum and those tailwinds, as you discussed, Dan. And I think we're going to keep seeing more and more that really pushes everybody, payers and providers, in that direction.
Dan, if I could add, just to build on that, one encouraging sign that we're seeing as part of our hospital at home users group, which has a few hundred members now of organizations and health systems and affiliates who are interested in hospital at home. We've been developing draft program standards and also draft quality indicators that could be used by CMS and the Joint Commission and NCQA. And we're in the process now of putting those out for comment in our own community. And there's been tremendous interest from those organizations like the Joint Commission, who are saying, wow, quite honestly, there's a business opportunity for them to survey hospital at home programs. There are opportunities for NCQA to help preserve quality and also, be in line with their own business model. And I think the real estate issue that Aaron brought up is not at all trivial. And, I often wonder whether we'll see a bunch of hospitals turn into condos or part of their infrastructure being repurposed for that reason. On the other hand, some people have said there are studies that suggest that the US is underbedded, depending on where you are. So the ability to create capacity without capital expenditures is great societal return on investment, because depending on where you are in this country, it costs between $2 and $5 million to capitalize a single hospital bed. And that's a lot of money.
Just to pick up on that and connect, there's some great questions in the chat. And so I feel some pressure to get to some of those questions. So there's one that relates to what you just said, Bruce, from Madeline Howard. What are common pushbacks, the idea of home health, and who are they coming from? Is it the hospitals, the SNFs, or other, more individual providers that are losing revenue? And let me just see if I can reframe that a little from what you said, is that one could imagine if you were like a central planner of the healthcare system, repurposing the hospital, but I don't think the hospital's so interested in that. And so, just kind of from a political dynamic, there are some groups that could win and some could lose. And so much of this, sector of the economy is a public-private partnership, which makes movement, there's a lot of people in our audience from other sectors where change might happen differently. And I guess, how do you get the hospital to go along with moving it to condos? They have to go out of business first? Will they
Yeah, it's a great question, Dan. I think, a few things. Number one is there, I think most people on this call, or everyone on this call, would know healthcare is incredibly local, right? So, the issue of capacity and supply of beds tends to be a very local issue. I've tended to think of hospitals, especially mid-sized hospitals outside of the most major metropolitan areas, tend to be the economic drivers for those geographies. So, they supply a lot of employment opportunities for the community and the like. That said, there are some hospitals who have taken this seriously. So one example, Mount Sinai in New York, when they started their hospital at home back in 2015, they started running ads in the New York Times, full page ads that said, if our beds are full, it means we failed. And they talked about hospital at home as one of several strategies to try and move care into the community. And then they put their, they not only talk the talk, but they walk the walk. When they tore down one of their 900-bed hospitals, they only replaced it with a 300-bed hospitals because they really wanted to try and move care to the community. And they saw it as in their own economic interest to do that, to help reduce the fixed cost and the feeding of the bricks and mortar beast that they had to do. So I think it tends to be a very local argument, depending on what the particular bed and demand characteristics are. There are winners and losers along the way, but I do think it's possible for there to be many, many more winners here than losers.
Yeah, and I would just add, because we fundamentally partner with health systems, so health systems and medical groups, and we see them jumping into this because they understand that if, as the provider, they don't, that the payers will do it around them, right? If it drives cost savings, if it's driving better quality, it will happen. And so we see organizations saying, we provide the best care to our patients. We're going to do this, even if it means that Mount Sinai example, ultimately tearing down a physical space. And, it just means different strategic decisions. And I think it has health systems, medical groups, all just rethinking the definition, of what the care model looks like, and that's a good thing for everybody that they're in that space of doing so. It doesn't mean that it's not hard, as we've talked about all the challenges, but there's enough folks really jumping into it. They see that this is inevitable. Do they want to lead it, or do they want it to happen around them?
I think I'd like to add from hospitals' perspective, they align the right kind of incentives. They're willing to move some of the care from the hospitals, especially right now. There's a huge provider shortage, or like health staff. I mean, a healthcare staff shortage. I was talking to one of the health systems, one of the major health systems yesterday, and then literally they were like, okay, let us set aside everything else, the technology and other things. There's a huge shortage in people managing our patients. Is there a way that your technology, or some company who can actually help us to manage the shortage? So if you go in with the proposal to the such health systems, offering them the right kind of incentives, I think that will probably move the needle. But it's still going to be a long process. I don't know. I really hope we don't have the same kind of challenges 5 years from now. We don't want another pandemic to change our mindsets. Hopefully one is good.
I'm gonna read so many great questions here. There's a number of them that connect to just kind of building out just informationally a little bit more about the home, hospital at home model. And so you can kind of expand as you'd like on this series of questions. So how much time are providers spending in the home with the patient, or is it mostly through this remote monitoring? How is it going to modify long-term care? What percentage of patients would have been admitted to a hospital that are now admitted to a hospital? How many of them would otherwise qualify for at-home care? And then something about like connecting, does it connect to the EMR, the hospital system, and things like that? So I know it's a lot, but you guys have been great so far. I just wanted to get this kind of informational questions out there, and also just express the curiosity of the group to just learn more. So I'm just going to throw it to the three of you. And
I could start with a couple of them. Let Safia and Bruce add on. So for our experience, just to frame up the patient a little bit more, our average age of our patients in medical home started off at 81 a couple of years ago, and has actually gotten down to about 67, partly because of COVID. I'm seeing a lot of COVID patients that have that younger profile and more commercial payers. So thinking about, sort of that patient with congestive heart failure exacerbation, with any number of types of infections, pneumonia, COVID that has sent them into the hospital. One of our most acute patients, as a patient that had a bone marrow transplant, would have spent 14 days in the hospital and was able to come into the home after just 2 days. And there's a number of visits during that phase, which is really replacing the hospital care. It's typically about 4 to 5 visits in the home a day. That might be from a community paramedic, it might be from a nurse, it might be from a phlebotomist, whether it's infusion activity, supporting that sort of virtual assessment with the physician who's rounding on the patient once a day virtually. So it's quite intense care, and some patients have, Q12, and it really extends into the evening hours. So it's truly that replication of hospital care in the home. And as we look at the opportunity of patients that can come in really focused on hospital care in the home, it's somewhere between 20 and 30%, inevitably the range. We've studied this with many different health systems of patients that could move into the model. You start to then look at other continuum needs. I saw someone's comment in the chat relative to bringing them into the ED only then to bring them back into the home. We think you can do ED replacement. And we've done that for 3,000 patients here in the Boston market, such that you're not having to create that. Now, again, regulatory reimbursement structures need to support that. But when you start to extend into those types of needs and extend it to even more preventative care, that number will grow, but true hospital replacement tends to be somewhere between 20 and 30% in our experience.
Just to build on that, one comment that Erin made that I just want to focus on a bit is this notion of, hospital at home, emergency department care at home. One of the great things that they do is they interrupt the usual glide path of care, right? So I'm going to relate this back down to, I think, the question you said about how this might influence long-term care. So if you're a patient in a hospital and you're getting a bit better and it's Friday afternoon and you're somewhere close to discharge, one of the glide paths, one of the paths is for you to go from the hospital to a skilled nursing facility for post-acute rehabilitation, post-acute skilled therapies, physical therapy, occupational therapy. And you flow, and then there's a flow from the skilled nursing facility to long-term care. A lot of great data to suggest that if you are taken care of in hospital at home, you're far less likely to go from a hospital at home bed to a skilled nursing facility bed at the end of your acute hospital at home stay. And part of that is because the glide path is just less simple. The supply sensitive service is less easily accessed from the home. And by doing that, you reduce the need, you reduce long-term care admissions as well. So, the ability to interrupt the usual glide path, reduce the use of supply sensitive services that may not be contributing to better outcomes, right? I mean, hospital at home has been studied in several scores of randomized controlled trials. Meta-analyses, some meta-analyses actually show reductions in mortality at 6 months with a ridiculously low number needed to treat of about 50. That is dead or alive at 6 months. There is no harder outcome than that. So, and part of that, at least my theory, we don't really know the mechanisms there, but I think if you're outside of the potentially harmful environment of the hospital, you're not going to the skilled nursing facility, not going to the nursing home, you can avoid harm. That is not to say that hospitals are not necessary. They are. We are not Luddites. There are many people who absolutely need to be in bricks and mortar, but a lot of them really don't need to be there. Your other question, people tend to be connected to the EMR of the hospital. That tends to be a very system specific issue. And I think there was a question about the percent of hospital at home folks who get home care. I'm interpreting that as the percent who start in hospital at home, come to the end of their acute phase of care, and who may need post-acute skilled home health care. My experience, that number tends to be around 20 to 30% as well. It depends on the population. It just depends.
And Satya, can you speak to the connectivity of your device to EMR systems? And
yeah, absolutely. I think right now that this is our device, I don't know if guys have seen it. So what it does is,
Come on, put it, you can show it longer. Let's take it, there we go.
that's our
Cool.
advice. So from usability, it's very simple. It's more like a breathalyzer, but it's 4G enabled. So the data is connected to our cloud and from there, from our platform, but we have integrated with at least one major electronic medical record. So for us, I think we believe our system acts, or like technologies can act as a way to determine who gets to do the hospital at home initiative, because we are looking into the acuity of the patient, like high acuity patients, like somebody who absolutely needs a hospitalization might not be a great candidate for hospital at home versus somebody who can probably have one chronic condition. They're still managing their health. Probably they are not, again, like a great candidate, but people within that, between those two spectrums are the right ones to get the kind of care that hospital at home can provide. And right now, again, one of the challenges is a lot of individual technologies. I don't know how much they integrate, but that's where platforms like, for example, Medically Home or other companies have platform. Even we have a platform where it acts as a central point where it collects all the data and then use it to push it to the EMR instantly, so that there is no lag. And providers can open, they don't have to go to another platform to open it and see something, but rather get it on their phone or on the EMR next to the patient or medical record.
So I want to just keep an eye on the clock here. We got about 10 or so minutes, and there's a lot of questions. I want to turn a little bit to kind of the addressing our business students here and to think about the future. But before we do, I just want to kind of collect another 3 questions that all are on the theme around equity in some way, and how these models that we're talking about interact with equity. Some things that have come up in the Q&A, but also in the conversations is, the home has to be at least, at some level of an actual home to be able to deliver hospital at home technological capabilities to use devices. If someone is isolated and doesn't have a caregiver at home, are these models still applicable? And then finally, there was another great question on, can social determinants of health be addressed? Social needs when you're actually there in the home in a way that couldn't otherwise. It's one big collection of questions on a theme. Again, you guys have done so great with my multiple questions that I'm gonna stop there and turn it over.
Yeah, it's such an important topic. And I mean, we like to think about the social screening for this being a very low bar. Yes, there needs to be some kind of home environment, although increasingly, we have health system partners thinking about other ways that they can provide that for a period of time if it's, the patient doesn't have a suitable home environment. But suitable is really a roof, running water, electricity. The part of the technology that Medically Home brings has the connectivity, has cellular coverage through two different coverage sites in order to make it that we don't have to rely on the patient having in-home Wi-Fi. We try to take everything out of the mix that could create a limitation. And there's a number of things that our clinical team has come up with for the social stability screen that are really about problem solving for social determinants that may be for that patient. So we can bring home health aides in if there is not the appropriate support to ensure that in the most frail early days for the patient that they've got that additional care for just regular daily living items. We've cleaned homes. We've brought in cleaning if that was going to make the patient have a more suitable environment. And I'm sure Bruce can speak more to this, but seeing the patient's environment, understanding how they actually really live is so important for changing that trajectory. And that's what's so powerful in being able to create that connection and tailor a care plan that will not only meet that patient's needs in the moment, but actually beyond, I think is one of the most powerful things of the model.
Just to build on that, I agree with everything Erin said. I think, you know, when you are in someone's home, you are seeing their social determinants, period, full stop. And you get to modify those, and you can understand, you know, medication adherence, because when you walk into the home, you see a bowl on the kitchen table that just has loose pills, and it's just all the patient's pills. And you say, how are you managing your medicines? And you know, I can think of at least 24 visits like this over the years where people say, well, you know, Tuesday I take 2 blue ones, and on Wednesday I'll take 2 red ones. So the ability to actually do medication reconciliation in someone's home at the kitchen table with the bottles, that is true medication reconciliation. What we do in the hospital when we send people home is really, really science fiction. I think the other key issues here is that when you're in someone's home and you are a professional guest, it changes the power equation in the home. And it creates an ability for patients to be a little bit more trusting because you are on their turf and you are behaving a bit differently. We found in the Center for Medicare and Medicaid Innovation demonstration we did of hospital at home at Mount Sinai, that when we stratified the population by Medicaid status, it was the patients who are eligible for Medicaid who derive the most benefit in terms of reductions in post-discharge ED visits at 30 days and hospital readmissions at 30 days. The issues of caregivers, very important, very important. I would say that is an area that hospital at home needs to do a better job of coming up with a more standard game plan. We went to CMS in the mid-90s asking for payment waivers, and what they told us at that time was, very interesting model, but all you're doing is substituting family for hospital staff, and we took that very seriously. So when we did all of our early studies, we never required families to do anything. It was all provided by nurses and home health aides and the like. If they wanted to help, we could educate them. We never asked them to do things, but there is variation in that across programs.
So I'm going to segue, Satya, and just tee you up first. You know, I think this was incredibly inspiring for our business community that wants to, you know, make a difference in people's lives. So maybe you could help provide a pathway and help think about what are the opportunities for our participants with the business skills to make a difference and earn a living doing it. So doing well by doing good, or however that works. And just turn it to you to share your thoughts on that.
Absolutely. And I think the first thing I want business school students is to take a risk. I think like 90% of them don't do that. And oftentimes, I mean, I just always talk about my story. Like I met my co-founder at Carey Business School. I was the only one who walked out of the room when he presented a solution to really go and help him out. It took 7 years, but I don't mind. And today, like we are actually can save a patient's life. So, which is where I think education adds one layer, but also taking the risk at very early stage. And then especially a lot of technologies and innovators come out of different health systems. Like take Hopkins, like we had at one point we had like around 30, 40 inventions come out, but there's nobody to move past that initial prototype, right? Which is where there's a huge value there for business school students to actually take it out there, create a company, and then just go actually make it as a real company and product. I really think healthcare is fastly moving. There's a lot of need for decentralized care, decentralized trials. So I think we need innovators or experts or people who are willing to actually help improve these processes from hospital at home to also specifically around like digital therapeutics. A lot of efforts are in that area where we need business leaders who find the new markets, find non-traditional players to actually make a real impact in healthcare so that the traditional players can actually follow and then add value in the long run.
So we've got about 2 minutes left. Anyone want to follow up and offer some ideas of emerging roles or areas where there's a need in the future for people just starting out their careers.
Yeah, I mean, I'm a business person at heart, so I can really relate to this group. I think there's so many roles in this space, whether it's as in the investment world, right? That how are dollars being invested towards transforming care for this set of patients? There's lots of business roles in the provider community. At Medically Home, I think we're a compilation of entrepreneurs, technologists, clinicians, engineers, all coming together to try to tackle and solve big problems. And that takes a lot of business mindset and strategic mindset, driving the fundamental decisions of how all of that comes together. So I think there's so many avenues to take that business background and apply it to solving these problems or many others that we can do better in healthcare. And I don't think that has to be really working for a provider. Somebody who came from the consulting world, I've never worked at a provider organization, but always worked around it in interesting ways. And so I think there's a lot of things to explore.
Thank you, Erin. Well, we are, I think what we'll do is give a quick round for some final thoughts, a couple of words to just leave us with, to maybe encapsulate something that stuck out in your mind from today's conversation to sum up. Bruce, I'll start with you for this on-the-spot quick summary.
That is on the spot, and you didn't warn us on that one. I would just say that, I think this stuff is coming. I think the hardest thing is to predict the lags. I don't know when. And there are risks. The payment model could fall off a cliff if Congress doesn't do things, but I do think it's inevitable. It is shifting that way. I've been at this for a long time. I'm hoping to retire at some point in the future, and I'm hoping it will continue to move forward.
Any final thoughts, Satya?
No, I strongly believe the technology, the people behind it, everything is moving in the right direction. For us, what we really need is health should be perceived as like, okay, I'm working out, I'm eating the right food, but also taking a little bit more efforts in terms of preventative health. Not a lot of efforts is taken to preventative health, and we really need to change the culture of health monitoring and then taking a little bit more ownership of everybody's health, which I believe should change, not just with older people who are sick, but also younger generation students should start in terms of better taking care of their health. Mental health is not only a problem, physical health is also important.
And Erin, I'll give you 30 seconds if you have some final thoughts.
It's just a really exciting time in healthcare. I think there's lots of uphill battles to continue to fight, but the focus on the patient, if we all keep focusing on that as the center of what we're doing, I look forward to seeing what a talented group like the group on this phone will actually drive over the next 5 to 10 years to keep this momentum up.
Thank you. I love that final thought, the focus on the patient, focus on the customer. Is a great way to encapsulate our conversation today. So with that, I want to just offer some thank yous to our amazing panel. Thank you, Satya, Erin, Bruce. Really, that was just so much fun to interact with you and hear your thoughts. Just really terrific. Thank you so much.
Thanks, Dan.
And I also want to thank our amazing team at Carey for organizing this, and just an amazing group that keeps us all, this all happened because of you. Thank you to Kira and Meredith and Philippe and Tim, and of course, Alex. So with that, we will say goodnight to you all and hope you have a great evening. Thank you so much for attending our event.